First symptoms of vitamin A deficiency is night blindness, while impaired pupillary constriction to the light illumination is the first sign of vitamin A deficiency. Deficiency of zinc can also lead to secondary vitamin A deficiency because of different mechanism. The transportation of vitamin A is through retinol binding protein, which is zinc dependent, as well as conversion from retinol to retinal is also zinc dependent reaction. So deficiency of zinc can also lead to secondary vitamin A deficiency. Welcome back to my channel. In today's video we are going to learn many one-liners and many clinical based MCQ on vitamin A deficiency. Do not skip anything, watch till the end. Let's get started. Hi, I'm Dr. Triyavirani Malde, pediatrician and consultant neonatologist. I'll be your guide for pediatric subject. If you are new to my channel, please do subscribe and give like to this video because lot is going to happen for pediatrics on this channel. So question number 1. Most abundant form of proVitamin A is? Read the question carefully. It is written proVitamin A. So what is the most abundant form of proVitamin A? The correct answer is option A, beta carotene. To understand this question, we need to know what is vitamin A. Vitamin A, as we all know, it is fat soluble vitamin. It is basically in two forms, preformed as well as proVitamin A. Preformed vitamin A is mostly of animal origin and it is called retinoid. Retinol, as well as retinoic acids. These are all animal origin retinoid. While non-proVitamin A and proVitamin A. What is the difference between these two? ProVitamin A can be converted to retinol, though it is of plant source, but it could be converted to retinol, while non-proVitamin A cannot be converted to retinol. The examples of non-proVitamin A are lycopenes, lutein and xetazanthine. If lycopene is having anti-cancer properties, it's protect against prostatic carcinoma, while lutein and xetazanthine prevent the macular degeneration. So this is just a revision. Vitamin A is a preformed vitamin A, retinoid, only animal sources, fish liver oil, kidney, egg yolk, halibut liver oil, more than the cod liver oil. Retinol is very important for reproduction. Retinal, we all know, retina and retinal. Retinal 11-cis is for vision. Retinoic acid is for growth and cell differentiation. If bound to fatty acid, become retinyl esters. Non-proVitamin A, carotenoids. Carotene comes from carrot. So this is all the vegetables and fruits of orange yellow colors are having rich source of carotenoid. ProVitamin A, we all know, beta carotene and alpha carotene. Carrot, papaya, sweet potatoes and mangoes are the rich source of beta carotene, and it is having antioxidant properties. So next question is name of the factor which is responsible for uptake of vitamin A in the liver. So from the bloodstream, the vitamin A is taken up by liver, and for that uptake, which factor is responsible? Your options are A, ApoE, B, ApoB48, C, ApoB100, or it is D, ApoA. We are going to learn the absorption of vitamin A and transportation of vitamin A in detail, but just as of now, remember the correct answer is option A, ApoE. As we discussed that beta carotene is a plant source by retinyl esters that is bound to the fatty acid. So from beta carotene to retinol, we require dehydrogenase. Retinol is again reduced to retinal and then it binding to the free fatty acid and it is getting converted retinyl esters if it is from the beta carotene. While the animal source, retinyl esters is converted to retinol and again retinyl esters to taken up by the intestine, where it is incorporated in chylomicrons, and with the help of it's getting circulated in the blood, bound to the chylomicrons, and this chylomicrons with the help of ApoE factors taken by liver. Here it is converted to all trans retinol and then it is converted to retinyl palmitate. Retinyl palmitate is also a type of retinyl esters, and then it is stored in the Ito cell of the liver. Ito cell is also known as a stellate cell or hepatic perisinusoidal cell. What is happening to a storage form? Once it is getting stored and whenever it is required, that retinyl palmitate, that is basically retinyl esters, again getting transferred to retinol, and this retinol with the help of retinol binding protein transthyretin comes back to the blood and will act on the peripheral tissue. As we already discussed few functions of vitamin A, it is very important for the eyesight. Retinol is for retina. It has an anti-cancer property. It is very important for the healthy epithelium of respiratory system as well as the gastrointestinal system. It is important for the maintenance of immunity. It helps in a bone growth as well as cell growth. Last but not least, it is important for the reproduction as well as the healthy growth of the embryo. Next question is, retinol palmitate, storage form of the vitamin A is stored in which cell of the liver? We all know it's just a revision. Is it hepatocyte? Is it Ito cell? Is it Kupffer cell? Or is it hepatic endothelial cells? The correct answer is Ito cell or a stellate cell or a hepatic perisinusoidal cell. Vitamin A gets absorbed from which part of the intestine? Your options are A. Duodenum, B. Jejunum, C. Terminal ileum, or it is D. Large intestine. The correct answer is jejunum. For this, we are going to remember this figure. Jejunum is a major site where the carbohydrate, protein and fat, it's getting absorbed. So along with the fat, all kind of fat soluble vitamins, that is A, D, E, K, is getting absorbed in the jejunum, as well as in the last series of vitamin B12. We have learned one mnemonic. Dude is just feeling ill, bro. So iron is getting absorbed from duodenum, folate is getting absorbed from jejunum, and B12 is getting absorbed from ileum. So according to that also, folate, that is iron, is also getting absorbed in jejunum. What is RDA, recommended daily allowance of vitamin A in the children? Is it 400 microgram? Is it 500 microgram, 600, or is it 450? This is just a number we have to remember. The correct answer is 400 microgram per day. For the men it is 600, for the women it is 600. In the lactation and pregnancy it becomes 900. Lycopene, that is protective against which cancer? It is non-provitamin A. It is protective against which cancer? Colorectal carcinoma, CML, lung cancer, or it is prostatic carcinoma. This is also revision. Lycopene is non-provitamin A, which is giving protection against prostatic carcinoma. Called no provitamin A because it cannot be converted to retinol. Vitamin A deficiency is observed with all of the following medical condition except zinc deficiency, malnutrition, cystic fibrosis, as well as acute diarrhea. And correct answer is acute diarrhea. We are going to discuss that why zinc deficiency will lead to vitamin A deficiency. Malnutrition, we all know when the child is going to end up with the many multiple vitamin deficiency, and vitamin A is one of them. In a cystic fibrosis, there is malabsorption of many substances. Along with this, the fat soluble vitamins are not getting absorbed. So vitamin A, vitamin D are the commonest vitamin deficiency which is seen associated with cystic fibrosis. But in acute diarrhea, we are not having any kind of vitamin A deficiency. So what are the causes of vitamin A deficiency? Obviously, if the diet is not having enough supplements of vitamin A, like in a case of malnutrition, in a multiple disorder of jejunum, like chronic diarrhea, celiac sprue, or a cystic fibrosis, there could be a decreased absorption of vitamin A. Zinc deficiency can lead to vitamin A deficiency due to various mechanisms, and alcohol also lead to vitamin A deficiency that we are going to discuss in upcoming slides. So how does alcohol interfere with vitamin A metabolism? Your options are dehydrogenase enzyme, vitamin B1 transketolase, alkaline phosphatase, and oxidoreductase. Among all this, which enzyme is getting affected with the alcohol? So correct option is option A, dehydrogenase enzyme, and for this we are going to understand the Walds visual cycle. So we all know that retina is having rods and cones. Rods are responsible for dim light vision and it is situated at the periphery, while cones, you have to remember cones are at the center part of the retina, and that is responsible for the bright and the color vision. What is happening here, that liver is having a store of cis retinol. Cis retinol is getting converted with the help of alcohol dehydrogenase to the cis retinal. Now this cis retinal, remember retina and retinal, do not get confused, it's not nol. It is retinal. Cis retinal from the liver going to the blood, taken up by the retinal epithelium, and will be in 11 cis retinal form, will be part of rhodopsin. Rhodopsin is a pigment in which there will be a retinal along with opsin, that is protein. So it is combination of both, that is called rhodopsin, is important for the dim light vision. By the reaction of photoisomerization with the help of isomerase enzyme, transretinal can get converted to 11-cis retinal also. Now this transretinal will be again going back to retinal epithelium, will go back to blood, and this transretinal in the liver getting converted to transretinol with the help of alcohol dehydrogenase. Now, if there is alcohol presence, this enzyme getting used by the alcohol, so it will not be available for this reaction from transretinal to transretinol. This is the mechanism by which the alcohol will lead to the secondary vitamin A deficiency. What is this image showing? Is it a nyctalopia? It is xerophlamia? Is it Bitot spots, or it is carotenemia? The correct answer is option B, xerophlamia. Nyctalopia is a night blindness. Xerophlamia is a group of signs and symptoms in which there will be a spectrum of the eye disorder due to vitamin A deficiency. So whatever we are seeing here, a dry eye, dry cornea, dry conjunctiva, is called a xerophlamia. Here there is no visibility of Bitot spots, so this is also out, and carotenemia is not seen because carotenemia is ulceration and liquefaction of the cornea. So that is not seen. So correct answer is option B. So how to remember the classification of vitamin A deficiency? We have to remember that A is for conjunctiva. So in 1A there will be just dryness of conjunctiva. In 1B, remember B stands for Bitot spots. So 1B is for Bitot spots, 2 is for cornea. In stage 2, there will be only dryness of cornea, which is called xerosis of cornea. In 3A, the intense problem will be there in cornea. So 3A will be only ulceration, while 3B is carotenemia, which is liquefaction and ulceration of cornea. XN stands for night blindness, XS stands for corneal scarring, and XF stands for fundoscopic changes. So here this is Bitot spots. It's a triangular spot with wide base pointing towards the cornea. This is carotenemia, in which we can see the ulceration as well as the liquefaction of the cornea. These two figures are showing carotenemia because of vitamin A deficiency. So what are the symptoms? The progression of the stages of progression of the eye disease will be night blindness leading to conjunctival xerosis, Bitot spots, corneal ulcers, and carotenemia. Second thing that we have already discussed, that it is helpful and mandatory for the maintenance of the respiratory, GIT and urinary tract epithelium. So squamous metaplasia of respiratory and urinary tract endothelium could be a part of vitamin A deficiency, as well as there could be a follicular hyperkeratosis or phrynoderma, that is toad-like skin due to vitamin A deficiency. So earliest symptoms of vitamin A deficiency is conjunctival xerosis, night blindness, Bitot spots, or conjunctival dryness. Symptoms, it is written as a symptom, so night blindness is the earliest symptoms of vitamin A deficiency, while impaired pupillary constriction to the light illumination is the earliest sign of vitamin A deficiency. Many a times asked question is, what is carotenemia? Is it corneal xerosis? Is it night blindness, or it is ulceration and liquefaction of cornea leading to rupture and replacement of the normal epithelium by stratified squamous epithelium, or it is a conjunctival dryness? We all know the correct answer is option C, ulceration and liquefaction of cornea with rupture and replacement of the normal epithelium with the stratified squamous epithelium. The next question is stage 3B. We all know that 1 is for conjunctiva, 1A and B. 2 for only xerosis, and 3 is for A and B. A is for ulceration and B is for, correct answer is carotenemia. In which stage of vitamin A deficiency corneal xerosis is seen? Again, 1 stands for conjunctiva and the 2 stands for cornea. So correct answer is option B, stage X2. The recommended oral dose of vitamin A to be given in a 10 months old child with deficiency on each day 1, 2 and 28 is 50,000 IU, 1 lakh IU, 2 lakh IU, or it is 6 lakh. The correct answer is 1, and for this we need to remember this table. that if the age of the child is less than 1 year and if the age of the child is more than 1 year, less than 1 year, we are giving immediately 1 lakh, next day 1 lakh, after 4 weeks 1 lakh, and severe PEM 1 lakh. So here it is 3 doses are given on the 0 immediately, on the next day, and on the 14th day. If the child age is more than 1 year, then the dose will be double, 2, 2 and 2. Toad-like skin is seen in which vitamin deficiency? A, B1, D or biotin? Just now we have discussed. Correct answer is vitamin A. This is toad-like skin, which is also called phrynoderma. It is follicular hyperkeratosis which is seen in multiple dietary nutritional deficiency, namely vitamin A as well as essential fatty acid. Which of the following reason is responsible for vitamin A deficiency secondary to zinc deficiency? RBP is zinc dependent, so transportation is compromised. Retinol to retinal is zinc dependent reaction. Zinc reduce release of vitamin A from liver storage. Actually, all of these three lead to secondary vitamin A deficiency. Retinol binding protein is also zinc dependent. The conversion of retinol to NAL is also zinc dependent, and zinc reduce the release from liver. Now it's a clinical case scenario. A 52-year-old male with Crohn's disease come to physician because of 1 week history of dysuria and urinary urgency. He had been treated with UTI twice in 6 months. He is currently taking infliximab. Cystoscopy shows pearl-like plaques on the bladder wall. Biopsy of these lesions shows focal layer of stratified squamous epithelium with hyperkeratosis. If patient's bladder finding is because of vitamin deficiency, which of the following is most likely to be seen? Night blindness, circumcorneal neovascularization, which is seen in riboflavin deficiency, photodermatitis, or a carpopedal spasm. So there are many clues in this question. First of all is having Crohn's disease. Crohn's disease are associated with vitamin deficiency. Most of the time it is associated with vitamin D, but it could also have vitamin A deficiency. Secondly, the symptoms are suggestive of urinary tract, so dysuria and urinary urgency. And the cystoscopy shows pearl-like plaques on the bladder wall, which is stratified squamous epithelium with hyperkeratosis. So correct answer is night blindness, because whatever symptoms has been described is because of vitamin A deficiency, and this is the most earliest sign of vitamin A deficiency which we can predict in this patient, that is night blindness. Now the next case, a 72-year-old was brought to the physician by her son because of 2 months history of recurrent diarrhea and respiratory tract infection. Her son says that she frequently trips over the nightstands when she gets up to go to the washroom at night. Physical examination shows dry skin, multiple bruises on the shin of the tibia, triangular keratin plaque on the temporal half of the conjunctiva. A deficiency of which vitamin is underlying cause of this finding? Options are ascorbic acid, retinol, niacin, or it is a riboflavin. Now here also there are multiple clues. First, she is having recurrent diarrhea and recurrent respiratory tract infection. So it is pointing towards vitamin A. Second, she trips over the nightstands. Again, it is the earliest symptoms of vitamin A deficiency, that is night blindness. And that is the most common presentation. The mother will say that child cannot find her in the dark. Physical examination shows dry skin, multiple bruise. Now multiple bruise will tempt you to tick over the ascorbic acid, but this bruise could be because of her tripping over and her repeated injury to the tibia. And there is a keratin plaque on the temporal half of the conjunctiva, that again part of a xerophlamia. So correct answer is option B, retinol. The third clinical case scenario is a 32-year-old lady comes to physician because of easy fatigue and yellowish discoloration of skin. During this period, she is also having 6 kg of weight gain. She doesn't smoke but takes 1 glass of wine daily. She follows a vegan diet, and her diet consists mainly of spinach, kale and sweet potatoes. Physical examination shows yellowish discoloration of skin. Her hands are cold to touch and her nails appear brittle. Eyes examination shows no abnormalities. Which of the following finding is most likely in the patient's serum? Decreased heptoglobulin concentration. What is heptoglobulin? Heptoglobulin binds to the free RBC. So whenever there is a reduced in the concentration of heptoglobin, it points toward the hemolytic anemia. Increase alkaline phosphatase concentration, it points towards the liver damage. Increase beta carotene A concentration, it points towards beta carotenemia. And positive anti-HAV antibody, it points towards hepatitis A, in which we are having jaundice. Okay, so now we are going to discuss the symptoms. The first thing is having easy fatigue and yellowish discoloration. Second symptoms is having a 6 kg of weight gain. She doesn't smoke, but she takes wine, 1 glass of wine daily, which is not that significant to this, pertaining to this case. But here is the important clue, that she follows the vegan diet, and her diet is very much rich in all these 3 things, and all these 3 things are a very high source of carotene. And physical examination shows discoloration of skin, but there is no mention of discoloration of sclera, so there is no jaundice. Jaundice is absent, and whenever the jaundice is absent, this 1 and 2, A and B, is out, because in a hemolytic anemia also there will be a icteric tinge in the eye. And in the case of liver injury, there should be icterus. Even this is also out, because hepatitis A will also present with jaundice. Here is the another clue, that she is cold to touch and her nails appear brittle. There are 3 clues which points towards the hypothyroidism. She is having 6 kg of weight gain, as well as her feet are cold to touch and nails are brittle. So this points towards the hypothyroidism. As well as one more important thing, that eyes are normal. So they have mentioned that there is no jaundice in the eye. So basically these are all symptoms and signs pointing towards the increased beta carotene concentration, that is called carotenemia. So what is carotenemia? It is because of excessive consumption of the food rich in beta carotene. Like as mentioned in the case, it could be associated with hypothyroidism, diabetes mellitus, and anorexia. Here this patient is also having symptoms of hypothyroidism, 6 kg of weight gain, along with cold skin, brittle nail, and only discoloration of skin, no jaundice, because it will reduce the conversion of active form of the vitamin A, and it causes yellowish discoloration, but there is no jaundice. In well-fed person, vitamin A store lasts for more than 6 months, less than 1 month, 3 months, or 3 to 6 months. In absence of all kind of other concurrent deficiency, it should last for more than 6 months. The next question is not seen in hypervitaminosis: A. Alopecia, polyuria, pseudotumor or liver damage. The correct answer is polyuria. Polyuria is seen in vitamin D hypertoxicity, but not in vitamin A hypertoxicity. So what are the features that is suggestive of vitamin A hypertoxicity? We have to remember SAD pH. Skin desquamation, alopecia, anorexia, dry skin, hair and mucous membrane, diplopia, pseudotumorcerebri, and H stands for hyperostosis of tibia as well as hepatosplenomegaly. It is seen in Arctic explorer who are basically consuming more of a polar bear liver. Hypervitaminosis of which of the following will cause bony abnormality? Options are vitamin A, D, C or K. The correct answer is vitamin A. So what is hyperostosis? The other name for this bony abnormality is dripping candle wax appearance. Like if the candle is burning, there is a dripping of the wax. Similar appearance will be there in hyperostosis of tibia. That's all about today's lecture. I hope you all understood and learnt well. Your suggestions are always welcome for the improvement. Please let me know what else you would like to learn from me. Till that time, take care of yourself, study hard as well as study smart.